we have a very special keynote address by Dr. Ashok Nanda, who will be speaking about how we prevent posterior capsular rent.
Thank you, Piyush, and good morning, everybody. Though we are going into discussion of complications or complicated cases in cataract surgery, I would be talking something preventive, which is good to know about how to prevent PC rent. We all know PC rent is something which you do not want. It's an unwanted guest. And so we have to know about the risk factors of list of risk factors which can actually cause PC rent so that we can prevent. It's not moving, yeah. So PC rent is something which is either pre-existent or can be a surgical complication, and as a surgical complication, it has an incidence of incidence of about 1 to 4%. Why it's going on its own? I'm not doing anything.
Can somebody from audio visual please help out? So it's moving ahead without his moving the cursor, and it's also
go back one slide, please.
The ratio is also not correct. Abhi ho gaya.
Okay, one slide. पीछे जाओ भी हाँ. So there are पीछे जाओ पीछे आगे जा रहे हो आप. और एक. Yeah. So the incidence of PC rent during surgery varies from 1 to 4% and depends on various factors which we will be enumerating. The patients who undergo cataract surgery, if they have a PC rent, there is a 30% probability of having a complicated post-operative recovery with incidence of post-operative inflammation, cystoid macular edema, retinal detachment, increased hyphema, cortex retention, and secondary glaucomas, corneal edemas are pretty high. Placement of a IOL, especially in a toric lens, is a real challenge. So it's better to prevent and understand what are the predisposing factors. We divide the predisposing factors into 4 categories: equipment related, patient related, eye related, and surgeon related. So in the equipment related, it can be a microscope or phaco machine going faulty. Patient can be prominent eyebrows, deep set eyes, narrow palpebral fissure, spine problems. Eye related could be corneal, antechamber, or iris and lens related, and surgeon factors, of course. So a patient with increased age, having back problems, too much of anxiety, breathing issues because of COPD, all these increase risk of PC rent. Inadvertent head movements due to Parkinson's, Huntington's chorea are also high-risk patients. Deep-set eyes cause pooling of irrigation fluid and causes reflections, reducing visibility, and exaggerated Bell phenomenon causes jerky movement of the eye. Visibility issues can be due to corneal scar, corneal dystrophy, spheroidal degeneration, pterygium covering the pupillary area, band keratopathy, and so on. Cataracts can cause PC rent, especially if there are intimation cataracts, black cataracts, posterior cataracts, or cataracts associated with trauma or lentiginous and lentiglobus. These are high-risk cases. Pseudo-exfoliation per se is a high-risk surgery where you have a chance of jugular dehiscence and PC rent. Small pupil is one of the most common cause of PCR due to senility, eye phase, post-synechiae, long-term use of topical pilocarpine, pseudo-exfoliation, and diabetes. So there is little visibility issue and PC rent. Shallow antechamber due to phacomorphic glaucoma or anti-angle closure glaucoma. It leads to doing phaco in a very shallow chamber, leading to PC rent. And deep antechamber due to high myopia causes general laxity, lack of scleral rigidity, and trampoliting effect of the posterior capsule. Pars plana vitrectomy causes lack of vitreous support and lens touch. So machine related, if you are not familiar with the phaco machine that you are handling, and if there is a sudden surge, if there is a collapse due to irrigating line getting blocked or bottle finishing midway, then there is a risk also. Faulty setting in the microscope where the brightness is poor, coaxial illumination is incorrect, focus is not proper, or there is a fogging below the eyepiece, then in that case there is a high risk. Surgeon related factors could be lack of experience, fatigue, See, when there's a long list of surgeries, this surgeon, who is me, of course, is trying to do a posteropolar cataract and trying to aspirate out in with a phaco tip, which is bad, and you are likely to, of course, I escaped here, but you are likely to have PCR in these cases. To begin with, prevention is a good preoperative evaluation and starts with history taking. Ocular trauma history is a must. Ask for previous surgical procedures like pars plana vitrectomy. Examination of the fellow eye is very important because if the previous eye has been operated, and look for complications, whether the previous eye had any complications. Always prefer a peribulbar anesthesia than a topical in high-risk cases, and of course, general anesthesia or sedation is necessary. Reduce IOP whenever you feel that there is a risk by giving mannitol. Intraoperative visibility should be, as I mentioned, microscope should be good with good coaxial illumination. Speculum use you must remember that the size of the speculum and the weight of the speculum should be taken into consideration. Too tight speculum can increase the upthrust of vitreous, leading to PC rent. Wound construction has to be done done properly because vitreous is a good culture medium, so it has to be a good sealing wound. Too small wound causes wound burn, and too big wound causes chamber instability due to wound leak. Pupil dilatation should be done either with some pupillary expanding devices, iris hooks. If there is synechia, it has to be released. Rhexis, a complete rhexis is essential. Aim to have a bigger rhexis. Keep a micro scissor ready if in case you are dealing with a hypermature cataract with a anterocapsular plaque. Hydrodissection has to be gentle. Remove antechamber, some of the OVD from the antechamber before hydrodissection. Inject small amounts. Tap the nucleus gently in between so that you prevent capsular block syndrome. It is quite likely to have a PC rent when you are trenching in a soft cataract because the posterior capsule comes off very easily. Be careful. Even in a hard cataract, the sharp edges of the pieces can cause PC rent. Posteropolar cataract, no doubt, is something one has to be very careful. Anyway, I'll skip the video for lack of time. While doing irrigation aspiration, avoid tilting the irrigation port to the down to polish the capsule. So in case it catches the posterior capsule, you have the converging folds on the tip, towards the tip of the irrigating port, and it's called a spider sign. If you have a spider sign, immediately stop and reflux and release the capsule. While inserting IOL, when you do it with a hydrophobic lens, especially in a cold condition, there is a possibility of sudden jerky release of the IOL, and that is one of the important reasons. So it has to be a gentle injection of IOL, especially in cold areas. The injectors have to be checked. Sometimes it is also tight, and when you push, it goes with a jerk. This is a hydrophilic lens where it's a plate haptic lens. It was loaded improperly, so while coming out, it reversed and flipped upside down, causing a PC rent. So to conclude, identify the presence of predisposing factors, make appropriate modifications of your surgical plan, and mitigate the risk factors to prevent PCR. In case there is a PCR, identify early and manage. Do not panic. Thank you.
Wonderful, sir, for this lucid presentation. There were so many points that you covered. Maybe for a younger surgeon, if you can say your top 3 pearls of how they can avoid a PCR, just the top 3.
Good visibility. Never compromise or continue surgery if you are not seeing well. Any step that you are seeing should be visible to you. Number 2, try to achieve dilatation properly. That is very important. And number 3, which I feel is your most of the times your irrigation aspiration is the step where there is a little higher risk of PC rent. So that has to be gentle. More PC rents I have found in my fellows happening during doing irrigation aspiration. One has to be gentle about that.
Thank you. Thank you, sir.